Good evening, everybody. Today we are going to discuss a very interesting topic, chirally pure antihypertensive. What are the recent developments and the way ahead? Now, when we look at the current signs of chirality, it is an upcoming trend in therapeutics. The word chirality is derived from the Greek word chir, meaning hand. Because like hands, the molecules are not superimposable with their mirror images by any combination of rotations or translations. And you can see the chiral objects below. Now, what is the harm of ignoring chirality in medicine? All of us know the Phocomelia disaster in 1950, which shocked the entire world. The pregnant ladies were given Phocomelia as an antiemetic drug for morning sickness, and the babies were born. They had Phocomelia, as you can see on the slide. Later on, we came to realize that this molecule has two enantiomers, the R1, which has a sedative action, and the S1, which is responsible for the teratogenic and Phocomelia. And when we separate the pure form R-isomer, it is being used currently for cancer, AIDS, and erythema nodosum. So very clearly indicating that chirality can do wonders, and in this case, can eliminate the devastating side of a drug, maintaining its efficacy, beautifully demonstrated by elimination of Phocomelia after the chiral molecule was synthesized. What is the utility of chirality in cardiology? The classical example is S-amlodipine, which has antihypertensive effect in half the dosage of amlodipine without the troublesome side effects of the racemic amlodipine, that is, it usually does not produce peripheral edema. Now, recently, the chiral switches are utilized in therapeutics, not only in cardiology, in diverse specialties of medicine. As you can see right on the top is S-amlodipine, S-metoprolol. The gastroenterologist utilized in S-pantoprazole, and there are several other subspecialties of medicine where chirality is being utilized. Now, 2019 came with a breaking news when the calcium channel blocker S-amlodipine was approved by USFDA, and this came as a big booster for S-amlodipine. The FDA approved adult dose of S-amlodipine 2.5 milligram once daily, and you can increase it to 5 milligram once daily, and this provides effect of amlodipine or equivalent to 5 milligram and 10 milligram. The drug has also been approved for pediatric population 6 to 17 years, and here the dosage is 1.25 milligram, which is equivalent to 2.5 milligram of amlodipine, and 2.5 milligram, which is equivalent to 5 milligram of amlodipine. And the drug is also approved for using as monotherapy or in combination therapy, and provides equivalent effects of amlodipine in half the dose, which means it can be combined with a RAS blocker, it can be combined with a beta blocker, it can be combined with a diuretic. The drug was already approved in India in 2002 and in China in 1999, and is already available in Asian, African, and the CIS countries for several years. Now, when the data was submitted by China for USFDA approval, these are the trials which were submitted. But the FDA was very clear that for approval, it is only the bioavailability and the bioequivalent studies are required and not the clinical study, because we already have a lot of data from amlodipine. So only a cursory review of the top-line results of the efficacy studies was conducted, and the drug was approved in the dosage which I have already mentioned. Now, when we look at the bioequivalent studies on your left, you can very clearly see that the curves of concentrations of S-amlodipine and amlodipine are virtually superimposed over each other, even up to 168 hours. The Kanjuri is the S-amlodipine in India, and the Norvasc is the conventional amlodipine in India. So you can see the bioequivalence and the bioavailability is exactly same. When we look at the pharmacokinetic data, you can see on the right side of the screen, it is also very similar. The studies were also done in underfed and fasting conditions, and you can again see there is no difference whatsoever. So the bioequivalent studies were identical, and on this basis, the drug was approved. Now, all of us know amlodipine exhibits chirality. It has an S-isomer and an R-isomer. The S-isomer is the only vasoactive enantiomer of amlodipine, and it is 1,000 times more potent than the I-isomer, and is responsible for the antihypertensive action. Whereas the R-isomer, it has hardly any blocking effect on the calcium channels and is responsible for peripheral edema due to dilatation of the precapillary arterioles. So the racemic amlodipine or the conventional amlodipine contains the R and the S isomer in 1:1 ratio. When we purify the pharmacologically active S isomer, this produces equivalent effect of amlodipine in half the dosage and is devoid of the troublesome peripheral edema which we see with the use of amlodipine. Now, this is the leader study, is a large study, 10,000 patients, multicentric study, and patients were treated with 2.5 milligram levoamlodipine and 5 milligram of amlodipine. And the main study outcome was to assess the effects of levoamlodipine maleate and amlodipine on the occurrence of MACE in patients with primary hypertension. BP control rate was similar in both the groups. The trial has not yet been published, but this data is retrieved from USFDA site. You can see MACE numerically less in the levoamlodipine, that is the equivalent S-amlodipine in India. Death, coronary heart disease is numerically less. Stroke, again numerically less. Hospitalization for heart failure, numerically less. New developed atrial fibrillation, again numerically less. And marked decrease in the edema. Although the statistical figures are not available because the trial is not yet published, but we will be very much interested in the statistical significance of these parameters. Now, what is the evidence from India? It is important to bear in mind that the efficacy of amlodipine has already been established in large number of patients, several outcome trials. So the evidence of S-amlodipine is not much relevant, although we have trials from our country also. Now, this is the CISA study, the safety and efficacy of S-amlodipine. You can see when S-amlodipine was given in doses of 2.5 to your right side of the slide, the blood pressure dropped from 161 to 129, and the diastolic blood pressure dropped from 100 to 84 at the end of 28 days. When the dose was increased to 5 milligrams, the blood pressure dropped from 179 to 137, and the diastolic blood pressure from 107 to 86, clearly showing that there is marked fall in systolic as well as diastolic blood pressure with the use of amlodipine in this study, which was assessed at the end of 28 days. And interestingly, the edema was seen in very small number of patients. You can see 0.75% of patients, when with amlodipine, usually we see in 30 or more percentage of patients. Now, this is another Indian study which shows that when we use S-amlodipine in half the dosage, the reduction in blood pressure is almost same compared to twice the dose of amlodipine. And this is the CISA-4 trial results. And you can see at baseline, the systolic blood pressure is 156. The diastolic blood pressure is 97. And when we analyze at the end of 30 days, you can see dramatic reduction in blood pressure, 133, systolic 84, diastolic, showing a fall of 24 millimeters in systolic and 13 millimeters diastolic. The heart rate is also decreased by 4.8 beats per minute. Now, this is again the CISA sub-studies, the micro CISA 1 and the micro CISA 2. Now, let's look at the micro CISA 2, which has more number of patients, around roughly 340 patients. Now, amlodipine is a good drug for elderly patients because the pathogenesis of hypertension in elderly is due to increased stiffness of the vessels, and amlodipine has been proved to decrease the stiffness of the vessels. Now, what do we mean by this? Now, if you look at the normal vessel, the aortic pulse goes towards the periphery slowly, comes back slowly. By the time it comes back, diastole has already been initiated. This results in increase in the diastolic blood pressure and increases coronary filling. In those patients, that is the elderly patient where the stiffness of artery is increased, they are less compliant. What will happen when the aortic wave travels from the aorta towards the periphery? The aortic pulse wave velocities increase. It comes rapidly. When it comes, systole is already ongoing, and this produces a panoply of adverse effects on the arterial system, particularly the aorta. It will increase the aortic systolic pressure, the plaque may rupture, there may be increased load on the left ventricle, there's no diastolic augmentation, and the coronary filling is not increased. Now, this is micro CISA 1 I'm talking about, and this is a trial carried out in isolated systolic hypertension, which we commonly see in elderly individuals. Look at the baseline blood pressure, 155, and when we give S-amlodipine, the blood pressure slowly drops week by week, so that by the end of 4 weeks, the blood pressure has dropped to 133. So there is a reduction in blood pressure by 21 millimeters of mercury, which is great. And this also shows that the diastolic blood pressure also drops weeks by week, and there's a substantial reduction in the diastolic blood pressure also. Now, all of us know the Indians are hyperenergic, their heart rates are faster in the office, even at the home. And this is the Indian heart study, which was published in recent past. This also showed when the heart rates are examined either in the office or in the home, they are above 80, clearly indicating there is increased energetic activity in the Indians. And when we relook at the results of the CISA-2, besides reduction in systolic and diastolic blood pressure, you can see the mean heart rate also drops when S-amlodipine is used from 80.8 to 77.3. And this may be also useful in hypertensive patients, because we know if your hypertensive patient has faster heart rate, the outcome is bad compared to a controlled hypertensive whose heart rate is not fast. Although there's a borderline increase, not much. Now, when we analyze the pedal edema in the CISA-2, you can see out of 793 patients out of 2,200 patients, 40% have pedal edema. But the resolution of edema was seen in 93%, when amlodipine was switched to S-amlodipine. So 1.9% patient on S-amlodipine had pedal edema. There was a marked reduction. Now, how does this molecule fare in patients with comorbidities? As you can see in this slide, you need not need the numbers. Right on the top, you can see it also produces good response in coexistent diabetes. The middle one is coexistent dyslipidemia, and the bottom one is associated ischemic heart disease. All these comorbidities are very common in hypertensive patients. So it produces good response in all these comorbidities. The statistical p-value is significant. Now, what happens to edema if the patient is on a combination therapy? Now, this is a study where leg edema was analyzed in patients who were receiving amlodipine and the conventional amlodipine, the triple therapy for hypertension. And you can see that S-amlodipine, the edema scores were much less statistically significant compared to the conventional amlodipine. Now, you must be aware of that there are other molecules also in the market which have been claimed to produce minimal pedal edema. As we talk for S-amlodipine, you have cilnidipine, you have benadipine, you have efinodipine, and acylnidipine. But what is very important to remember is that it is true that newer calcium channel blockers and listed above decrease proteinuria, unlike amlodipine, which does not. But in renal diseases, mere decrease in proteinuria may not slow down the trajectory of chronic kidney disease unless it shows slowing of rate of decline of eGFR over a long period of time. None of the calcium channel blockers have shown this effect. No doubt they decrease proteinuria, but there's no documentation that they slow down the trajectory of chronic kidney disease. So if proteinuria is present in a patient who is taking amlodipine, you should combine it with a RAS blocker, telmisartan or mesartan, which has long-term proven benefit, not only in decreasing proteinuria, but also slowing the rate of decline of GFR. And if the proteinuria is still there, the next choice is SGLT2 inhibitors, because they slow down the trajectory of kidney disease on top of RAS blockers. And in future, you will be having the third magical molecule, the non-steroidal mineralocorticoid, which has been shown to decrease the slowing of, which has been shown to further slow the fall in GFR. So at the moment, we have proven RAS blockers, which came in 2004. Then came SGLT2 inhibitors. Both have proved that they slow down the rate of decline of GFR. And the DAPA-CKD, the top line results also shows that SGLT2 inhibitors will also decrease proteinuria in non-diabetic patients. So although the 4 new calcium channel blockers, they've shown to decrease proteinuria, no doubt, but there's no documentation that they slow down the trajectory of kidney disease. In anti-diabetic medication, we have gliptins, we have GLP-1 receptor agonists, they also decrease proteinuria, but they have not shown to decrease the trajectory of chronic kidney disease. So if a patient on amlodipine has proteinuria, the wise decision will be to add a RAS blocker. If it is not controlled, add an SGLT2 inhibitors rather than switching to newer calcium channel blockers, which have not shown to decrease the trajectory of CKD, although albuminuria has decreased. Now, S-amlodipine, smaller studies have also shown relief of angina, but the drug is not approved for angina. Now, what are the pleiotropic effects of S-amlodipine? As you can see in this slide, it has pleiotropic effects. It increases nitrous oxide and the endothelial nitrous oxide synthase and offers pleiotropic effects. It also has pleiotropic effects on the insulin resistance. You can see when we compare losartan with S-amlodipine, the systolic blood pressure decline is similar. The fasting insulin is also similar at the end of 36 months. The insulin sensitivity index, the 2-hour post-glucose, and the insulin sensitivity is also same by the end of 36 months. So the next question arises, what is the clinical place of this S-amlodipine? Now, all guidelines these days universally recommend combination therapies. And preferably, it is better to start with a dual combination, which could be a RAS blocker, a CCB, or a diuretic. And because S-amlodipine produces effects just like amlodipine in half the dosage, does not have edema, I'm sure the conventional amlodipine will be replaced by S-amlodipine in near future in all combinations of drugs which are commercially available. So whether stage one pill combination, or you have having two drugs, or one pill with three drugs, the choice would fall on S-amlodipine in conjunction with the RAS blockers and the diuretics. Beta blockers in the Western guidelines are not included in first-line drug, but Indians, we have a lot of patients of isolated systolic hypertension in the young, and these patients respond beautifully to beta blockers. So although not recommended in the Western guidelines, we use beta blockers several times in hypertension in the young, and amlodipine, which produces mild decrease in heart rate, may also be beneficial. The other molecule which is available is S-metoprolol, and this has been used in the treatment of hypertension, in treatment of angina, in treatment of heart failure. And this is a study, SMART CSI study, which showed that a fixed dose, a combination of S-amlodipine 2.5 plus S-metoprolol, both S drugs, is an effective and well-tolerated drug in reducing blood pressure in hypertension. This is another Indian study which shows this S-metoprolol, a chirally pure form of racemic metoprolol, has lesser side effects, is safer in COPD patients. The conventional beta blocker produces a lot of side effects in COPD and diabetes who also have hypertension. And this is again a review of the Indian studies. You can see S-metoprolol is not only tried in hypertension, hypertension with coexisting COPD, hypertension, and it has shown good results. It has also been tried in angina, hypertension on angina coexisting with diabetes mellitus, and the results are good. And it has also been tried in heart failure and hypertension in combination with angina, and it has shown good results. When we look at the RESOLVE program for hypertension control in India, this is a program which is executed in India and some states in conjunction with WHO for the rural population. And what do you see? What is the drug of first choice in the RESOLVE program? It is amlodipine, amlodipine, and amlodipine. And the reason for this is that amlodipine does not produce side effects, does not require lab monitoring, no edema with S-amlodipine. So again, in times to come, this amlodipine will be replaced by S-amlodipine. And this is adopted in several states, Kerala, Punjab, and several other states. This is the data of 2017 and 18. When we are treating hypertension, it is very important to remember that hypertension is an asymptomatic disease in vast majority of patients. The treatment of hypertension is a long drawn-out process over several years, maybe lifelong. So special emphasis should be paid on the quality of life. We must never forget that our hypertensive patient should not only live, they should also feel well. And here again, amlodipine scores over other hypertension. It does not disturb the quality of life. Now, why amlodipine for several years is considered as a first line in many subsets of hypertensions, either as monotherapy or usually we use combination therapy. There are many advantages. First, it has a very robust data for decreasing cardiovascular events in several large outcome studies, ALART, SCOT, BLA, PPLA, Accompany, and many other studies. We don't want to know. Very long half-life, producing 24 hours control of blood pressure in a single dose. Less BP variability and the highest smoothness index And if there were variability in blood pressure less, we know the strokes are less. Does not require lab monitoring in the long run and is very safe for long-term use in rural area. If you use a diuretic, you will require serum electrolyte, blood urea, creatinine, you may develop postural hypertension. If you use RAS blocker, you will again require electrolyte, you will also require blood urea, serum creatinine, and so on. But amlodipine, you prescribe the drug and forget, even in for months and years, it does not require lab monitoring because it does not alter any parameters to any signal. So this is again a very great advantage. Patient has not to visit the pathological laboratories again and again, unlike diuretics, unlike RAS blockers. But the problem with amlodipine is peripheral edema, which decreases the adherence of the drug and produces suboptimal control. If the patient develops edema, he will be very reluctant to use it again, and he may stop the drug without informing his physician. So is there any solution for peripheral edema? We have already shown the solution is S-amlodipine. So what are our take-home messages? That message is S-amlodipine provides BP lowering in half the dose with minimal or no peripheral edema. And it has already been approved by FDA, and this is a great boost for the practitioners, for the physicians, and all of us to use S-amlodipine in place of the conventional epinephrine because it has several advantages. And so the dicta is replace amlodipine, replace S-amlodipine, replace amlodipine with S-amlodipine. And these are the several reasons, because it can be utilized as a first line, either as a monotherapy, small number of patients, and in combination therapy in many patients. S-amlodipine increases patient adherence to the drug, provides optimum BP control with improved CV outcome, does not require lab monitoring for electrolyte, urea, creatinine, and so on. Once a day dosage, very convenient due to its long duration of action. It can be used in any stage of hypertension with any coexistent disease. So it can be used in all patients without any hitch and hesitation. It covers the black population also, which do not respond to the RAS blocker, less metabolic load and better tolerability. And I'm sure in future, all combination pills which are available with conventional epinephrine, they will have S-amlodipine, just as we saw hydrochlorothiazide being replaced by CTD in isolation or with various combination therapy. So the biggest advantage of S-amlodipine is it can be ubiquitously used in any hypertensive patient. Whatever may be the hypertension, without any ifs and buts, you can straight off use amlodipine. Not unlike any drug, you have to see what is the electrolyte, whether the patient has CKD or not, whether the patient autonomic neuropathy or not, patient has postural fall or not, and so many things. So thank you very much for your kind attention.
Thank you, sir. Thanks a lot. It was indeed a very informative and very good talk. And I think it has helped all the attendees who have actually attended this session. And we would just move on to the Q&A section now. And there are some questions. Sir, there is a question. It's a very basic question, like why like S-amlodipine is better than cilnidipine? Like where we will place S-amlodipine compared to cilnidipine in bed literature?
The cilnidipine and amlodipine. Amlodipine has a very large outcome data.
Sir, am I audible?
Yes. Amlodipine has a very large outcome data as a time-tested drug. Cilnidipine is a new calcium channel blocker, and the advantage which they claim is it decreases proteinuria. Amlodipine does not decrease proteinuria, but as already explained, if you have a proteinuria instead of cilnidipine, which has no outcome data on proteinuria, it has never shown to slow the trajectory of kidney disease. Best thing is to add a RAS blocker if you still have the problem, as SGLT2 inhibitors. And in future, if you still have a problem, the trial is going to be released very soon. you can add non-steroidal MRAs, that is mineralocorticoid studies. So although the neocalcium channel blockers do have the beneficial effect of proteinuria, but mere proteinuria you cannot make it equivalent to slowing the declining GFR and CKD. So that is the status of the new calcium channel blockers and the amlodipine.
Okay, sir. Sir, one thing is there in Indian population, in Indian hypertensive population. Sir, one is that diet-wise we are very, we are on the higher side of salt intake. Our salt intake is salt intake, sir. Our salt intake is a little bit higher side. And second is compliance is a big factor in India, because after 6 months to 1 year, many patients, they stop taking their medication. So, sir, how do you tackle these things clinically?
In hypertension, you must remember the drug which will be successful, which does not have side effects. And in hypertension, we want our patient to have adherence to the drug. If you use diuretics, they go to the office, particularly the lower class, they may not have a good place for the toilet, so they are hesitant to use diuretics. If you use a RAS blocker, it's a good antihypertensive drug, but it also has the problem of electrolyte problems. It may have the problem of postural hypotension in the initial stage and several. But amlodipine has the advantage that it produces smooth control of blood. The patient is not required to visit lab. Patient is not required to go to the hospital again and again. And if your blood pressure is not controlled, certainly you can add the other two drugs, that is either a RAS blocker or diuretic. But when we talk of adherence, amlodipine is on the top. It doesn't interfere with the quality of life, doesn't interfere with sexual function, doesn't produce postural hypertension, no electrolyte imbalance, no monitoring. So amlodipine has a lot of advantage. And it is adherence which is more important rather than the potency of drug. You may have a very potent drug, but the patient will give it up if it has side effects. So potency and side effects should run simultaneously. Very potent effect, side effect, the result will not be good. So adherence is very important in the management. And most of these patients are asymptomatic. If it is very difficult to make an asymptomatic individual feel better, he may be made worse. So while prescribing an antihypertensive drug, if you want the patient to take a drug for a very long time, which is the need, you have to prescribe a drug which does not produce side effects.
Correct. Sir, in your slide, you also showed in your presentation, you also showed one slide where, combinations are the preferred way of therapy currently. Even the guidelines are also recommending to start the, therapy as a combination, as the first line of the therapy. So, sir, do you think that even in the younger hypertensive, the patients who are diagnosed maybe in the early or late 20s or early 30s, they also can be started on the combination?
In our country, what we term this phenomenon as isolated systolic hypertension in the young. This is still being evaluated, but we have seen they respond very well to beta blockers because this is produced by stress. Most of the Indians of all class are in stress. The stress is different for the different subset of patients. And if you give beta blocker, they don't respond to RAS blocker, they may not respond to calcium channel blocker. But if following beta blockers, the response is not adequate or suboptimal, you can certainly add the second drug.
Okay. Sir, one more thing is that you told about the beta blockers. The beta blocker as such, over a period of time now, the usage has gone down. So is it because of that maybe a bad name which has come to beta blockers because of atenolol, and because of that, like good beta blockers like metoprolol, S-metoprolol, these are underused?
I think it is only the atenolol which was responsible for the side effect after that meta-analysis, because it increased stroke rate by 30%, MI by 13%, all-cause mortality. It has increased. And this effect is not common to all other beta blockers. Metoprolol is good. The other beta blockers, carvedilol is good. We have nebivolol, which is good. So beta blockers should not be given discredit as a class. It is atenolol which has problems, but metoprolol, carvedilol, even this nebivolol, all very good beta blockers for hypertension as well as for heart failure. So it is only the atenolol of the group which is not appropriate. All other beta blockers are very good and they are indispensable in angina and heart failure, and also used in selective subset of hypertensive individuals.
Sir, one thing is there, BP variability, as you told, like it is one factor, one very important factor in hypertension. There are some patients like night dippers. There are some patients like in the early morning rise also happens in the bit of, in the hypertensive patient. So, sir, what should be the timing of the drugs? Like it should be taken early morning or it should be taken in the late evening, or if it is a combination, then should we space it out?
If you use a single pill, the
Yeah.
compliance is less. If you use two pills, compliance is still less. If you use three pills, compliance is least. So always try to give a single pill. Compliance will be maximum.
Yes, please.
If the drug has a 24 hours action, it may not matter much what time. But there are some studies which have shown that if you give the antihypertensive dose at night time, it has produced comparatively better results. But the exact dosing pattern may be judged from the ambulatory blood pressure monitoring. If you have a morning rise, you are a non-dipper, we would like to give the dose in the evening or in the night. So, although ambulatory monitoring may not be used frequently, but I personally feel, particularly when there's discrepancy between the target organ damage, the blood pressure reading, blood pressure not well controlled, you must have at least once an ambulatory blood pressure monitoring to see what is the 24-hour pattern of blood pressure. What is the dipping pattern? Is it normal, paradoxical, or they are high dippers? And are there any morning surges? What is the variability of blood pressure? Because all these three parameters are important in the long-term prognosis of patient. And if all these three are abnormal, or whatever parameters are abnormal, you should try to target them with an appropriate drug. And for BP variability, which is not commonly targeted in our day-to-day practice, amlodipine has the highest smoothness index, and that's why amlodipine is preferred for targeting BP variability, as was shown in the Ascot BP-LA trial also.
Sir, one more thing is that in uncontrolled hypertension is something like which is might be seen in the 10% cases. So, sir, what is the if the patient is on already on combination and he's on uncontrolled hypertension, then what is the therapeutic approach for the patients?
See, in uncontrolled hypertension means resistant hypertension.
Resistant
It
hypertension.
means you are using a triple combination in appropriate doses, and this triple combination may be a telmisartan, maybe azilsartan, the most potent, or olmesartan, plus CTD, and conventionally we use amlodipine. And if it is still not controlled and you have excluded all the secondary factors, you have excluded that patient is adhering to the drugs. It's not that you are prescribing, he's not taking drug. If it doesn't respond, the next choice is aldactone. If the patient still does not respond, we have to use other drugs, which may be an hydralazine, which may be minoxidil, which may be arcamine, which may be moxonidine, and other secondary drugs also, even in the alpha blocker. But what is very important to realize is, if you don't initiate treatment early in the phase of disease, what happens? This arteriolar thickening, which is the major determinant of increased peripheral resistance in hypertension, it gets irreversible. So you prescribe a vessel, it does not dilate. And these patients are the ones where arterioles are virtually fixed. You give a vasodilator, you give hydralazine even, or you give minoxidil, they don't respond. So these patients who do not respond to 5 drugs, 6 drugs, they are perhaps in a state that their arterioles have thickened and fibrosed also to such an extent their peripheral resistance does not decrease. So what remains in these patients is you can decrease the blood volume by diuretics, but you cannot use very potent diuretics. So blood pressure, either you can decrease the blood volume or you can decrease the peripheral resistance. Now in such cases, the renal sympathetic denervation, which is going to bounce back, can also be tried. But the message is, if you diagnose and get your hypertension treated adequately in the early stages, this phenomena is not likely to occur. But it does occur in small percentage of patients, and the reason is your vascular system has virtually failed to respond to the drugs, and that is the reason very commonly seen in CKD patients where it's difficult to control blood pressure.
Sir, one last question. in the antihypertensive therapy, most critical thing is, even more critical than the medication is the BP measurement. And the BP measurement is something which, many clinicians find it very difficult to, adhere to the guidelines. Guidelines say that you do ambulatory blood pressure management and all, but practically it is very, very possible, very difficult to follow. So, sir, what is your take on that? What is the best practical approach to do the BP measurement?
The sphygmomanometers, which we have been using for decades, are out. We should not use, although it is still difficult to throw out immediately. Time has come, we must embrace digital technology. You must measure blood pressure with these instruments because that is more accurate rather than the manual. And the blood pressure instrument should be validated. All trials of hypertension, vast majority of them, long-term trials, have been done with the office blood pressure. You have some smaller trials with ambulatory blood pressure. So still, although the sprint trial showed the way which you measure blood pressure, you can rest for 5 minutes, you take blood pressure 3 times, nobody is going to disturb you, you are in an AC room, unattended blood pressure. That is not possible practically in the Indian context. So in the Indian context, it is usually the office blood pressure. You can also tell the patient to measure home blood pressure after being trained. Home blood pressure is good, office blood pressure is good, and you can also get an ambulatory blood pressure. All these techniques are complementary to each other and not competitive. For diagnosis of hypertension, you should have blood pressure measurements on several occasions, just as for diagnosis of diabetes, or you look at blood glucose, it keeps on varying. The blood pressure keeps on varying. It is an inherent property of blood pressure. It will never be static. So you should have blood pressures, multiple readings, office readings, home blood pressure you can have. But if there's a discrepancy, suppose a patient comes with blood pressure in the office is normal, he has target neuronal damage. This is a clear indication that he should go for an ambulatory blood pressure, if not possible, to the home blood pressure. Suppose his blood pressure is found higher in the office and not at home, again, this is an indication. Or if his blood pressure is not controlled. So all tests are complementary to each other. If you remember, the NICE guidelines way back recommended ambulatory blood pressure for diagnosis of hypertension somewhere 2011 or so. So blood pressure, you have to have multiple readings. Home is good, office is good, and you should try to complement whatever is possible, whatever is feasible. And ambulatory blood pressure at least once whenever it is convenient, feasible, to see the pattern, because you cannot see the 24-hour pattern of blood pressure at office or by the home blood pressure. And previously it was said that the office blood pressure, because the cuff inflates, it gives an awake nighttime blood pressure. But now this has been avoided. We have small blood pressure which you can put it in the fingers. It doesn't awake the patient. That gives a true night blood pressure. Otherwise, with the conventional office blood pressure which we are measuring, people have commented the patient wakes up. So you are not giving a night blood pressure, you are giving an awake night blood pressure, and it should not, it will not significantly reflect the true nocturnal blood pressure. So blood pressure is a dynamic thing. You cannot say blood pressure should stay there. It will keep on changing every minute or every hour.
Thank you, sir. Thanks a lot for your insights. And I think all these questions, a lot of things might be more clearer for the clinicians, and a lot of things about the hypertension management would have been a little more clearer. So we wish that we would have more time, than we would have extended this talk. But I think that's enough for the day. And we wish to have more such interactions, sir, in the coming time. And we would require you to, give your valuable time whenever we require in the future. So for today, sir, thanks a lot, and have a good night. Thank you.